The topic of doctors and healthcare providers comes up a lot on our podcast. It comes up a lot in my surveys, our doctor's visit survey. And a common theme that I hear, whether it's in the surveys or it's on social media, is that women in perimenopause and menopause are not listened to, they're not validated, they're not supported, they're gaslit, they're dismissed when they go in and they speak to their doctors and healthcare providers about their symptoms and how they're feeling. And we know that 40% of women are dismissed when they share their symptoms with their doctor. It takes anywhere from 2 to 5+ times that we need to see our doctor or healthcare provider before a connection is made between how we're feeling and it being perimenopause and menopause. And we also know that 75% of the time when we're visiting our doctor, we're bringing up the topic to them about possibly being in perimenopause and menopause. And only 10% of doctors bring up the topic to their patients. Only 10%. I mean, think about it. Think about how these numbers need to change over the next several years. And what's nice to see, though, however, is that more doctors are taking an interest in women's health and women over the age of 35 who are going into perimenopause and who are in menopause. More research is now being funded for women's health, which I'm thrilled to see, and also for menopause in particular, as we learned about when I spoke to Dr. Anina Burns, and she shared the funding that's available. So that's terrific too. So hopefully things will change. We'll see a complete 180 when it comes to how we're being treated by our doctors and healthcare providers, and also their level of education. And in September, when I attended the Menopause Society's annual conference, it was the first time that it was sold out. And this is a medical conference. So it gives me hope that things are going to change. And they are. They're changing, because I always like to say that us Gen Xers are not going into it lightly or quietly, because we are going to change the way it is for women who come after us. We're changing it for millennials. Millennials also are going to be vocal about it and are vocal about it. Gen Zs are learning about it from our Gen X generation. So we are not going to be quiet or silent, and we are not going to be taken by surprise anymore as we go into a phase of life that 50% of the population will go through if they are blessed to live long enough. So today's guest is amazing. I'm going to introduce you to her in a minute. She's a doctor, and a doctor that is very caring and understanding about us. And I can't wait for you to listen to today's interview. But before I introduce her, I just want to take a minute to introduce myself. My name is Andrea. I'm a nutritionist for almost 20 years. I'm a menopause educator and published menopause researcher as of December 2024. And if you haven't filled out our surveys, please do. We have currently 11 of them on our website. They take under a minute each to fill out, and your voice matters. We launch these surveys because we want to understand what you are going through. So please help us further our menopause researcher by taking a moment to fill them out. We always have new ones that we're adding. Our newest one is called Healthcare Insights, and we want to have your voices. We want to know that what you're feeling. We want to hear from you. And if you're also looking for a line of supplements that help with your symptoms and your overall health, please consider Morphus products. If you can go to our website, we are morphus.com. I put a link to it below. All of our supplements are third-party tested and backed by research and handpicked. These ingredients are handpicked by myself and my partner, Randy, who I've been business partners with for 25 years. So have a look at our line of supplements. It's at the top. Under shop, you can take a look. If you have questions, you can reach out to us, info@wearemorphus.com. Myself and my team, we get back to you and we answer your questions. So you always have someone to ask a question to if you want to understand our products better or if you want to understand how to use them. Today, I'm speaking with Dr. Elizabeth Beth Cilenti. With over 10 years of experience as a pediatrician and internist in the greater Washington, D.C., Northern Virginia region, Dr. Cilenti approaches each patient's health as a collaborative partnership, from providing well care to healthy babies and children as they grow and develop from day one, to helping parents navigate caring for children with special healthcare needs and chronic conditions. She values establishing long-term relationships with families and hopes her patients and their parents feel like they have found a doctor who really knows their family and their kids. And I have to tell you, I absolutely loved Beth. I thought she's an incredible doctor and physician. And I hope that if you live in the Virginia region, that you are able to go see her, because I truly believe that her patients are blessed to have her as their doctor. Now, here's Beth. Welcome to Menopause Reimagined, Beth.
Thank you so much. I'm excited to be here and excited to help talk about how women can get the most out of their health and well-being.
What we know and what we've discovered from our research is that doctors are, doctors need a lot more education when it comes to perimenopause and menopause. And as women who are going to see our healthcare providers, oftentimes we know that 40% of the women who are going to see their doctors are being dismissed or they're being gaslit. So there is a lot of work that needs to be done around the educational system, around doctors in terms of them understanding their patients better and listening to their patients and validating them. So can you explain what you are, explain what your specialty is, and then I'd love to ask you some more questions.
Absolutely. And I think this is a space where many people get confused easily and nobody really knows what exactly kind of doctor I am. So I'm dual board certified in internal medicine and pediatrics. So everybody knows what a pediatrician is. It's a doctor for children. I'm also board certified in internal medicine. Internal medicine is the non-surgical care of adults. So a general internist is a doctor who takes care of adults in either a primary care setting, sometimes a hospital setting. It's also the initial specialty that people will do before they go to specialize in many of the ologies. So, a cardiologist has done a 3-year residency in internal medicine and then gone on and done a fellowship in the cardiology subspecialty of internal medicine.
Okay.
Same goes for pulmonology, endocrinology. Those doctors who aren't surgical specialists have done an internal medicine residency first and then gone on to do additional training in a subspecialty. I practice general internal medicine, which is general outpatient primary care of adults. People will often ask, well, what's the difference between that and,
And a
say,
GP.
a general practitioner, a
That's
family
what I was
medicine
thinking.
doctor? So GP is kind of an older term for somebody who has
Hmm.
completed their initial medical school and usually a 1-year internship, but hasn't gone forward and done a board certification in any specialty. You really don't see a lot of true general practitioners anymore. What you will also see a lot of is a very similar specialty called family medicine. Family doctors train to take care of the primary care of adults of all ages. In their training, they get a little more training in minor surgical procedures as well as OBGYN, and some of them, particularly in um, the Mountain West, for example, will deliver babies and even sometimes do minor surgical procedures.
Okay, well, thank you for that. It's true. That's the first thing I was thinking is like, what's the difference between a GP, internal medicine? Like I've heard the term quite a bit, especially with our surveys, but I didn't really understand the difference. So thank you for that. That was a great explanation. I
Uh,
appreciate that.
Of course. So my training, we call ourselves MedPeds, like MED/PEDS. So we do a 4-year residency program combining internal medicine and pediatrics. So I spent 4 years essentially switching every 4 months between being a resident in internal medicine and a resident in pediatrics.
Wow, amazing. So you have seen, when we were talking before we started recording, we were chatting because you see women who have babies when they're older or babies like because pediatrics goes up to the age of 18, right?
Usually 18. Some pediatricians will see kids through college. So they'll kind
Hmm.
of keep
Okay.
kids through the, 22nd birthday. And once they're through with college, they, will transition them to adult care.
And in your case, they could stay with you forever.
They do.
That's amazing because you have that. Wow. Wow, that's awesome. Okay. So when we were talking about the fact that women, as we go into perimenopause and menopause, and let's say some of us who are having children later, like myself, excuse me, having children later, like myself. So what do you see from your parents, from your patients, as well as the parents that are taking them in, especially the mothers?
Yeah, I think it brings a whole new set of challenges when women have babies in their late 30s, their early 40s. I think there are some advantages. Women are usually you have a stronger sense of who they are. Perhaps they've delayed having a baby because it took them a while to find a partner that they feel like is a good match. Maybe they were working on a career. A lot of female physicians will delay having babies until later because they're going to medical school and residency. And so many of my colleagues have babies well into their 30s and 40s. But I think you also see that it puts a lot of additional stress and demand on the body. Um, when one gets into their 30s and 40s, is, I am learning myself, is you kind of can't get away with all the things you got away with in your 20s. In
Mm.
my 20s, I was a medical resident. I was taking call every fourth night in the hospital and usually not sleeping. And your ability to recover from that lack of sleep, um, that fatigue, I think really does change as one gets into one's 30s and 40s. So for women who are, having their first child in their 40s, it is acknowledging that that can be really hard, that, dealing with that lack of sleep as one is in,
Mm.
the 40s is a lot tougher than it is when one is in their late teens or early 20s.
Oh, it is. And we know now that fatigue is the number one most common symptom of perimenopause and menopause. So it's just like compound that with having babies. And I remember because I had my little one at 41, it's like it just the difference in how I felt postpartum was, I mean, it was a much easier pregnancy than it was with my first one because I knew what I was, it was like used,
Hmm.
I had done this before. But in terms of afterwards, the exhaustion, having a baby, having a toddler, and I was in perimenopause, that was now looking back, and I didn't know I was in perimenopause at the time.
Of course
Looking
not.
back, I'm like, whew, that was tough for sure.
Hmm. And I think too, women who kind of go straight from pregnancy and breastfeeding into perimenopause, oh, I just stopped breastfeeding and now my cycles are all weird. What could possibly going on? Is this breastfeeding? Is this perimenopause? Well, how can I be in perimenopause? I just had a baby a year ago. It seems that those two things should be separated, but they're not always separated in time, particularly for women who have, children in their late 30s and early 40s, perhaps even becoming pregnant while in perimenopause.
I love that you just said that, Beth, because for so long that was my thinking that okay, so I had a baby later, so I must be delaying menopause because I had a baby later, and then afterwards, and I also thought for the longest time my story went that I had my baby at 41, at 42, my postpartum symptoms never went away, and then all of a sudden I was experiencing all these symptoms that nobody else had. What was going on? I didn't know anything. This was 42 until I hit 47 and had my first hot flash, and I'm like, wait a minute, are all those symptoms I was feeling actually, postpartum, or were they perimenopause? So, and even me, I had that thinking of like, oh yeah, I can't be in menopause. I just had my baby. I'm 41. I'm going to delay that forever, or like at least until like my late 50s. So that is so bang on. And I actually want to do research around that because a
Mhm.
lot of women on my social media pages will say, oh yeah, look the same. Like I had my baby and then all of a sudden, I think perimenopause kicked in.
Yeah. Or, women who have a pregnancy and think they're perimenopausal and don't notice that they haven't had a period for a couple of months until they suddenly realize, oh, wait a second. So it certainly happens. We know that women who are in perimenopause can still ovulate, can still conceive. And so how do we talk with women around, managing those perimenopausal symptoms and then also managing, fertility and family planning?
Mm. So so being a doctor and that you're kind of taking, through the life cycle really of a person, when somebody comes into you, let's say a woman who comes in their 30s and 40s, what do you say to them? Like, because now you're familiar with perimenopause and menopause, you sound like you're educated about that. So thank you, by the way, thank you, because I cannot wait for more doctors and healthcare practitioners to become more educated around it. So tell us a little bit about, how you work with your patients, but also what are some tips that women like ourselves can bring to our healthcare providers so that they don't gaslight us, so that they don't dismiss us?
Yeah, I think, and I think zooming out a little bit is just looking at the healthcare system overall, is
Mm.
that it is really hard for honestly everyone. What we see in most practices for primary care is patients get somewhere between 15 and 20 minutes per appointment. So you're on the schedule with the doctor and you might be in a 15-minute spot, and which means your doctor has 15 minutes to both review what's happened to you before, remind themselves of the things we talked about at the last appointment, come in, see you, answer all of your questions, address any pressing needs, and wrap up that whole visit in 15 minutes. It is literally an impossible task to do as a physician who really wants to be present for patients. And I think that one of the big failings of our, healthcare system is that we shoehorn primary care into these, tiny short appointments, and specialists actually get longer with patients to deal with only one issue. But in primary care, you only get 15 minutes to deal with everything.
Mm.
So my current practice is a concierge practice, which means we charge an annual retainer fee in addition to billing insurance so that we can give patients longer visits, focus more on a preventative and personalized care approach.
It's interesting that you say that about concierge because that's how I've been with my doctor. I mean, we always pay for like as long as I can remember, we paid an annual fee, and then on top of that, she was able to bill the government, I guess the OHIP.
Mhm.
So and I love her because she takes so much time with her patients. I'm like the best doctor. So explain just, and so when you say that they only have 15 minutes, that's because that's all they're being paid for, right? So if they take longer, they're not being paid for that longer session. So if they take 20 minutes, they're not being paid for that extra 5 minutes. Is that what you mean about they only get a certain amount of time?
What it's usually set up as is this idea that in order to, run a successful business, most doctors are employed. So most doctors are schedules are being dictated by an employer, a health system. And in order to essentially keep the lights on and keep providing care is you have to pack more and more patients into a workday.
Mm.
And the way we do that is by people get scheduled in these, shorter and shorter appointments. Now, if you spend more time with someone, um, and provide really complicated care. Say someone comes in and is having a stroke in my office. We call 911 and provide that higher level of care. Yes, we might be paid at a higher rate than someone who comes in with a hangnail, but all of those other patients who are scheduled every 15 minutes are waiting in the waiting room, getting more and more annoyed because they are, waiting for their doctor who, told them their appointment was at 2:30 and now it's 3:15 and you're still sitting in the waiting room. So if you see a more complicated patient, it's possible that you could be reimbursed at a higher level, but those appointment slots are usually guaranteed in those 15-minute increments. And so it's just you're keeping those other patients waiting in the waiting room, even if you're
Mm.
dealing with a sick patient. And one of the things that was always sort of mind-boggling to me is that my hair salon can figure out by asking me a few questions about how long they need to schedule my appointment and for what services are going to be done. I don't understand why hair salons are so much better about this than, doctor's offices and healthcare, in that if you're coming in to discuss a hangnail, you probably need a shorter amount of time than someone who's coming in to discuss their new chest pain. And so I
Mm.
think that the system itself is just not well set up to serve the needs of the patients who are coming in. And you end up with this really one size fits all approach that doesn't really work well when you're taking care of people who are sick and scared and worried about their health.
Hmm. And it's so true. And I wish that doctors will get more, as I mentioned before, get more training in medical school about perimenopause and menopause. How much training do you
Mhm.
actually get?
Not much. You learn in medical school, the first 2 years are what we call the preclinical years. So you're learning the basic science approaches, the biochemistry, the physiology, how the heart works, how the brain neurons transmit. But it's not really a practical training until you get to your third and fourth year of medical school, which is where you're doing then clinical rotation. So you may spend a month on OBGYN, a month on surgery, a month on pediatrics, a month on internal medicine, and much of that is hospital based. So for many people, they don't get a lot of exposure to outpatient primary care.
Mm.
They may
Okay.
get some lectures and training in OBGYN and hormone management, but what they see is really dependent on where their rotations are done and kind of what patients they are exposed to. So I finished my medical school in 2008, which was in a time where hormone therapy was really kind of seen as something that was possibly harmful. So for many of us physicians who trained in the kind of immediate post Women's Health Initiative era, we didn't get a lot of exposure to HRT. The thought was Yes, you're having symptoms, they're consistent with menopause. That sounds really miserable, but I'm sorry, there's not really anything we can do to help. It's something you have to live with. So there wasn't a lot of education about how to support women through that, how to manage medications that might be helpful, or even what the underlying physiology was in a way that's meaningful. So, medicine you really learn as more of an apprenticeship system. You learn by being in the clinic, working with trained doctors. And so you learn from them how they talk to patients about blood pressure, how they talk to patients about diabetes, how you might counsel someone about, what advances are coming up for the next, developmental period in a 9-month-old baby. Probably they'll start pulling up and walking soon. But I really never got much mentorship in talking about what are the symptoms of perimenopause, what to expect, what you might see in the next year or so with how you're feeling, how your body reacts to certain things, what might change in your sleep. And so it's something where I think there's just hasn't been a strong framework for doctors who are kind of learning the ropes to learn about menopause and perimenopause.
So how did you learn?
So, how do doctors get educated now about menopause and perimenopause? There's a few different pathways. So, there are societies like the Northern American Menopause Society, which you've done some research and work with, which is a great organization. So, full disclosure, I'm not a certified NAMS provider, mostly because I have not gotten around to doing the test, doing the studying I think I would need in order to,
Mm.
successfully achieve that certification. And so what is left is learning how to take care of patients who are coming in with symptoms, who are asking questions. And I think one of the things I've learned is that it's okay to say, well, I don't know.
Mm.
I might not know right now, but let me do a little bit of research or thinking, and then going to different references, doing continuing education so that I learn how to help to answer these questions. And by being honest with women when they come in and saying, I'm experiencing all of these symptoms, to acknowledge that, yes, you are in fact experiencing all of those symptoms. This is not something that you are, imagining or attributing it all to anxiety or depression and saying, well, let's explore what could be going on underneath some of these symptoms and thinking about some treatment options we can use to help. So early on, I would find myself referring a lot to gynecologists who were NAM certified providers who could help with dosing hormone replacement therapy, help with evaluating some of these symptoms. By collaborating with some urologists and sexual medicine specialists and learning from the way they were taking care of patients and saying, well, there's no real reason why I couldn't prescribe that vaginal estrogen. And starting to talk to patients about genital urinary symptoms and checking in with women in their, mid 40s for looking for those symptoms and finding that
Mm.
so many women would be like, oh, yeah, no, I have noticed more vaginal dryness. I have noticed more pain with sex, but they hadn't thought to bring it up, either because it wasn't bothersome to them or because it was, but they didn't think they would be, heard, or that they just didn't know there was anything they could do about it.
Or it's embarrassing, you know? So as you're speaking, I'm like, okay, you are the type of doctor we all want. The fact that you just said that I don't know, I don't have all the answers, but you know what? I'm going to go look and do some research. I'm like, oh my gosh, your patients are so blessed to have you. And, women come in with, we now know, according to our research, that we have on average 31 different symptoms.
Hmm.
31. So you have 15 minutes to tell your doctor. That's why we have a like a checklist of all the
Hmm.
symptoms. We put little boxes that you can download. We'll put a link below if you want to get it. For those of you who are listening, you could download it, bring it to your doctor like Beth. So if you're seeing a doctor that only has 15 minutes, at least that helps save some time. If you're seeing a doctor like Beth where you have that concierge service, like that's great. You have extra time. but it enables you to say, here are my symptoms. So on average, like to think that we have 31 different symptoms, like it's definitely not a lot of time. That's why doctors like you are
Mhm.
a blessing for all of us, because A, you're listening to us, you're validating us, and you're supporting us. And then you're also like, if I don't know the answers, I'll go find them.
Yeah. And I think too is, if I don't know the answer, then who are my specialty networks? Who are the, people I can collaborate with to get, patients the help that they need? If you came in and said, well, I'm having this crushing chest pain and it's going down my left arm. And I said, well, I'm not really a cardiologist. I don't think I can help you with this. What I really need to do is refer you to the right person who can help you with that. And I think that's where having, provider networks of menopause certified providers or menopause, I guess I would say even interested providers is so important. So that if it's something that I can't necessarily feel like is in my wheelhouse to address, get that get that woman to the right person to help her with whatever symptoms she's having.
Menopause interested providers. I like that. I think we have
Yeah.
to coin that term. I think but it's true, right? So it's like at least they take interest in what their patients are going through and not dismissing and gaslighting them. So what are some things that our listeners can listen to? They're like, okay, so either if they're in perimenopause or menopause, how can they prepare themselves for a doctor's visit? What are some questions they can ask, so
Mhm.
that if they are gaslit or dismissed? I mean, we've heard some crazy things that doctors will say to our listeners, like, they're complaining, not complaining, but they're sharing that their symptom is they're gaining weight, and their doctor's like, well, eat less, exercise more. Or,
Mhm.
like it's just some, or if they have vaginal dryness or their libido, they have a low libido or loss of libido, it's like, well, go have more sex, that'll increase your libido. Like things that you're just like, what did they just say? Like, for real? So what are some things that we could do to prepare so that we are empowered? And I know for a lot of us, especially Gen Xers, and baby boomers, we go see our doctor. For a lot of us, our doctor is kind of like we put them on a pedestal as
Mhm.
opposed to, and everything that they say, and we're afraid to ask questions. We're afraid to take up too much space or too much time. What could we do to empower ourselves?
Hmm. I think one thing you can do, and I think one thing that's very helpful for me as a doctor, is to come in with your list of questions or your agenda items. And what I usually try to get people to do is tell me what's the bullet point? What is on your agenda today? So if your concerns are around sleep and hot flashes, give me those two bullet points first, and then we can start to dig into the more detailed symptoms. What often happens is people will go to the doctor, say, well, I'm really having trouble sleeping. And I, as the doctor, think, oh, great, this is a visit about sleep. And we spend all of the time talking about sleep and these, different things you can do, treatment options, diagnostic options. And then we get to the end, what I think is the end of this visit about sleep. And the patient says, oh, well, what about my headaches? Oh, I didn't know we were talking about your headaches today. And suddenly I'm realizing that, you may have had more things on your agenda that I didn't know about. So I think being really upfront with your doctor of, hey, here are the three things I want to talk about today. I want to address my sleep. I want to address my headaches. And I want to talk about these terrible hot flashes that I'm having that are keeping me up at night. And then that helps me to plan a little bit around the sleep and hot flashes probably go together. And so how do I look at that in that lens of all of the patient's concerns today? And sometimes people may tell me something that they don't think as their kind of main reason for the visit that I, as a doctor, might be really concerned about. And to say, hey, I think we really need to address this leg swelling that you're having, which could be a blood clot, when you really thought you were here to talk about sleep and hot flashes and these other things. And I'm worried
Mm.
about a serious condition that you might not have necessarily anticipated would be something that I might be really concerned about. So, being really upfront with your doctor about agenda setting and saying, hey, here are the three main things I want to talk about today, kind of helps both of us to set that agenda and kind of figure out what are the most important things to you and perhaps what are the most important things to me. I take care of a lot of patients with, multiple chronic conditions. And so, if you come in with a very high blood pressure, I'm going to be more concerned about that than I may be about um, dry skin. And so as the physician, as the person who kind of has that knowledge and expertise about, healthcare as a whole, kind of helping you to triage what's really important and what could be really dangerous, and then also making sure we address your concerns or make a plan for addressing them if we couldn't get to them at that visit.
Would they just have to schedule another visit? Is that how it would work? If you can't get through everything in one, do you schedule another one for like a week later, or like what would be a plan of action?
Yeah, I think in an ideal world, that would be great. I think what we know about the healthcare system is that so you talk to your doctor and then they say follow up in 2 weeks and you go out to the front desk and they tell you that the doctor's next available appointment is 3 months from now. And so that plan doesn't always work so well on an operational level. Sometimes I may say, hey, I know we
Yeah, right.
perhaps we didn't get as much time to get into that. Here are a couple of resources for you to do a little bit of, self-education, and then we can use that to inform our next visit. I'm in the position as a, concierge doctor in that I usually can get people back in. And one of the things that I find as a that I've learned over time is that if you give somebody a really long list of things to do, it can sometimes be really hard for them to um, kind of get all of that done before the next visit. It can be overwhelming. If I give you 4 referrals, 5 radiology tests to do, um, sometimes what will happen is you just get completely overwhelmed and you don't even know where to start. And so what I will try to do is break these into little chunks where I say, hey, here's kind of, I think, the first priority we should work on. Let's have you get this test done and see this specialist. And then I want you to come back and talk to me about what impact that's made and then kind of what are the other issues we still need to address. So sometimes with my patients, it'll be more of a 3 to 6 month plan of how we kind of attack these symptoms or really do more investigating.
So, as a concierge doctor, how much time do your patients have with you?
Most of my routine follow-up visits are around 30 minutes, but I have the luxury of saying, hey, this patient needs more time. And then we do once a year, what we call an executive physical. So we usually block those for 90 minutes. About the first half hour, 45 minutes is doing a lot of testing with our nurses and our clinical staff, and then the rest of the time is with me. And it's a nice way to sort of set an intention for the year, both in terms of all of the
Mm.
preventative things that women, particularly middle-aged women, have to do, which is a lot. Um, are we keeping cancer screenings up to date? And then also to kind of dig into some of those, health goals. How are you doing in terms of exercise, sleep, well-being, and taking care of yourself? And kind of making some changes then when you're in for a physical, which is a little less than, hey, I'm having symptoms that I need to talk to my doctor about.
So, what are some of the common things that you test your women who are in perimenopause and menopause, or let's say over the age of 35 for?
So, routine screenings for women who are over the age of 35 start with things like cervical cancer screening, women over 40, breast cancer screening, colon cancer screening for routine screening has now been lowered to age 45. For women who are in perimenopause, menopause, thinking about bone density, establishing a baseline DEXA scan. We also do in our office EKGs, some vascular testing for adults over 50, cognitive impairment screening for adults over 60, as well as hearing testing for all of our adults.
I am so happy you said, first of all of those, but I'm happy that you said the hearing testing because there is such a link now that between loss of hearing and dementia. So, yeah, sorry, go ahead.
Absolutely. So, interestingly, routine hearing testing isn't one of the recommended screenings through the U.S. Preventative Services Task Force, but we do know that there is a strong link between hearing impairment, decreased hearing, and dementia. In fact, it's one of the few things that people can actually do to prevent developing dementia. So I am I would say very vigilant. My patients might say I'm very obnoxious
Mhm.
about following up on abnormal hearing screens and talking to patients about getting a formal evaluation and thinking about amplification options, particularly hearing aids. There aren't a lot of things we can do to prevent dementia. Once people start to have those symptoms, but if someone is experiencing hearing loss or hearing impairment, then I think it's so important to really dig into that and to get those patients that, hearing aids and hearing amplifications, to keep those inputs in, to keep those centers of the brain active, and to prevent isolation and loneliness because you might not be going out to lunch with your friends because when you go, you can't hear a thing. And I think the other piece that is important for younger women to think about is hearing protection and hearing preservation. So if you are spending a lot of time at concerts, loud environments,
Yeah.
certain group exercise classes, is, thinking about wearing earplugs and hearing protection to protect your hearing, knowing that that's sort of one of the longer game actions you can take for cognitive decline and dementia.
I love it. I love what you're saying because I completely agree with you. And the other test that I'd love to add to that, that maybe you do or don't do, is sleep apnea, because
Hmm.
women aren't tested regularly for sleep apnea, but yet it is so common as we go into menopause.
Yeah, it's so common. As part of our kind of screening, we give people a homework assignment they take home, which has screens for anxiety, depression, the Epworth Sleepiness Scale, which is daytime somnolence and can be a sign of sleep apnea. And something that, I mean, to be honest, like I see so much of in, men and women too. So really digging into those sleep symptoms that women are having and testing and treating sleep apnea if we find it. And so it's something that I think can be really useful.
So, what are some questions that you believe? So, I like the fact that you come into your doctor's office prepared with the agenda, what you want to talk
Mhm.
about, what are the main things you want to discuss when it comes to your symptoms. But are there any questions that perhaps you're like, you know what, not enough of my patients ask me this, that we could put on our list when we do
Mm.
go see our doctor?
I think a great question to ask your doctor about are particular recommendations for exercise. It's really interesting. The protocols for screening for pre-participation in exercise have gotten a lot more liberal, but every time you go to the gym, every machine has a little label on it that says consult your doctor before you use this machine um, for, exercise. And I think that can be really intimidating, but I think talking to your doctor about readiness for exercise and particular exercise recommendations. I will give you the flip side of that coin, which is just like doctors don't learn a lot about menopause and perimenopause, many of us don't learn a lot about exercise science and exercise physiology, but it's becoming more and more common for, um, healthcare providers to recognize the importance of exercise, and to really check in with their patients about what exercise they're doing and what exercise they're not doing. So one of the things I really talk to my patients about is the importance of all exercise, but particularly strength and resistance training.
Yeah.
Um, I find so many people don't even know where to begin. Some people don't even know what strength or resistance training is. So they say, wait, am I supposed to go to the gym and start bench pressing? Questions I hear, well, is swimming resistance training? Is yoga resistance training? Is Pilates strength training? Because there are so many different things one can choose to do. And sometimes people don't know even where to start. So one of the things I will tell women is that strength training is so important. We know that it reduces cardiac risk. We know it improves metabolic health. It can help improve bone density. It can help with mood. It can help with energy and sleep. And so it's something that I tell my patients that if you are paying me as a concierge doctor an annual membership fee, you should have me at least once a year completely sell you on the benefits of exercise. because there is so much good that can be done from exercise and so many health benefits that you get throughout life that there's nothing I can recommend more. The other thing I will say is that it's never too late to start exercising and it's never too late to start strength training. So for women who are in perimenopause, in menopause, and postmenopause, that even if you've never done strength or resistance training before, now is the time to start.
Yeah, like I interviewed Melissa Hyde and she was talking about lift heavy shit. And so,
Mhm.
for definitely super important for all the reasons you mentioned. And talking about metabolic health, I mean, we're more prone to insulin resistance, we're more prone to blood sugar issues. What are your thoughts on, I mean, because I'm a big believer in continuous glucose monitors just
Mhm.
to understand what's happening. So I'm not, you don't have to wear it all the time, but also just to understand what you're eating and how it affects your blood sugar or your stress levels, how it affects your blood sugar. What are your thoughts on patients who come in and you're looking at their fasting glucose, but they're not in the pre-diabetic or diabetic ranges when it comes to a continuous glucose monitor and nutrition in general?
Mhm. Um, I think they can be a really valuable tool, particularly for someone who is really trying to, fine tune their nutrition, fine tune their diet. I think, there's a whole spectrum of knowledge around nutrition and, food literacy. And I think there are people out there who, um, have really optimized their diet. They've kind of figured out how many different macros and micronutrients they need. And I think for people who are really interested in that fine tuning, that it can be a really valuable tool. I also have patients who really don't have a lot of nutritional knowledge. They don't really know much about the difference between a carb and a fat and a protein. And so for those patients, I think that, some more basic education is probably a more valuable tool than handing them a continuous glucose monitor that they may not even have that underlying knowledge to kind of understand why certain foods are raising their glucose in a way that other foods aren't. And I think that, really helping women to understand what their bodies need and to nourish themselves is so important. And I really try to tailor that to, each woman in front of me. If a woman is interested in, say, starting a strength training program, then I might talk a lot more about protein goals. If I have a woman who's worried about a risk of diabetes and is interested in getting more of that real-time feedback that a CGM can provide, that's something I can certainly, help them to get or help them to interpret.
I'm listening to you and I'm just thinking, like, you're so balanced and I love your approach. And for so many women, when we go to our doctor, we have to fight for things. Like, so
Mhm.
women have told me they wanted to get a CGM and they can't because their doctor said they don't qualify for it. And they're like, well, wait, I want to know what it's doing for me. But it's like constant art, it's constant fighting and it gets so exhausting, right? Or if they want their
Mhm.
thyroid tested and the doctor won't test their thyroid. If they do, they'll test their TSH, their thyroid stimulating hormone, but they won't test their free T3. They won't test their,
Mhm.
their free T4. Like it becomes exhausting for us. And I listen to you speak and it sounds to me that you go to where your patient is at and you listen to your patient. And I just want to commend you because I don't hear this very often. And, from the women from the women in our community, and like I said earlier, I just think your patients are very blessed to have you as their doctor. So can you tell me so I know you're in Virginia. Like, are you able
Mhm.
to practice telemedicine? Tell us a little bit about how our community can get in touch with you.
Yeah, so I do practice in Northern Virginia. Most of my patients are patients who live near here, and I see both adults and children. I think what might be a little more useful is thinking through with women how to find a doctor that will meet you where you're at and how to find a doctor who will listen to you and meet your needs, which I think can be hard. I will say
Very hard.
nobody goes into medical school because they want to brush people off and dismiss and be seen as somebody who doesn't really care about the patients they are working for. So there's something deeply wrong with our healthcare system when it takes people who really do want to help and take care of people and turns us into the kind of doctors that feel like our hair is constantly on fire and you're running around and frazzled and can't really meet patients where they are or answer their questions or make them feel heard. So I think that's the bigger problem is that our health system is not set up to support really anyone in achieving their, best health outcomes. Our system is set up to fix things that have already broken. Inpatient care, hospital care, we're very good at taking people who are very sick and getting them back to almost as healthy as they were before, which wasn't very healthy to begin with. So I think for women who are in menopause and perimenopause who are trying to have their best health and stay healthy, that it is an absolute uphill climb to find healthcare providers who are set up to do that. I think ways to do that include setting up an initial appointment when you're not necessarily in crisis, if you can, to talk about your health goals, your doctor's philosophy around how to be proactive and preventative. And if you get the sense that this is someone whose philosophy is much more about taking care of people who are already far down the path of illness, then maybe that's not a doctor that's the best fit for a woman who's pretty healthy and wants to stay that way. I think that it is worth looking for different models of care, whether that are things like concierge or direct primary care, which is where doctors don't interact with the insurance system at all, and looking for doctors who are willing to do a brief, what you would call like a meet and greet. So to say, hey, I'm interested in getting a sense of this doctor without necessarily coming in, taking off all of my clothes, getting weighed, getting the blood pressure, and actually engaging in a medical visit. But is there a chance to meet with that doctor for a brief introduction? I think most of the doctors who are doing that are in the concierge and direct primary care space. But I think it for women who really want to be proactive about their health is it's worth looking into, making that investment in your health and helping find someone who can partner to keep you as healthy as possible as you go through perimenopause, menopause, and age.
And one of the biggest things I hear as well from our community is that it's so hard to find a doctor.
There's a huge shortage. There's a shortage of primary care physicians. There's a shortage of healthcare providers in general, and I think it is really hard. So I unfortunately don't have the answer to that. Um, but I think to just acknowledge that that is a very real concern that I think all of us should have, that it is really hard to find a good primary care doctor or someone who can help keep someone healthy who isn't spending all of their time trying to, play whack-a-mole with people who are really sick. And those people need doctors too. So I think we also need to advocate for, you know, change to our healthcare system that can help to make it possible for doctors who want to be preventive and proactive and help patients who are not yet dealing with all of those many issues.
Hmm. Is there anything that we didn't talk about today? I mean, I know we covered a lot of ground. Is there anything that you would like to leave with our audience before we end the interview?
Oh. Um, I think find yourself a doctor who you feel like is a valued partner in your care. I always try to tell patients that I may be an expert in healthcare in general, but you are the expert about your body. I tell parents, I may be an expert in children, but you're the expert on your kid. So if you're getting this feeling that something isn't right or something doesn't feel right, is to make sure you find someone who will listen to and honor that feeling, even if what you think it is doesn't turn out to be what the actual problem is finding someone you can partner with and have that strong therapeutic relationship and get what you need so you can have your best health and be as well as possible for throughout the life course and spectrum of aging. So I think one other thing that I would mention about perimenopause and menopause, which is having its day in the sun right now, is the one thing I do worry about is that perimenopause and menopause may begin to be blamed for other issues. that women may come in complaining of symptoms that can go along with menopause and perimenopause and be told, oh, well, you're just in perimenopause. This is just the symptoms you are experiencing. So I think that for both healthcare providers who are menopause interested and for women who are going through menopause and perimenopause is that yes, it can cause so many symptoms and they can be so varied, but we also need to be sure that we're investigating other things that can cause those same symptoms and not just doing what's been done to women for a long time, which is attributing things to anxiety or depression. And I don't want perimenopause to be the new it's all in your head of women's health.
That is so important what you just said, and that goes hand in hand. You always have to go to your doctor, get things checked out, get that clean bill of health, and then if they can't figure out or if there is no other reason, then you could be like, "Okay, maybe it's because it's a perimenopause or menopause symptom." And that is 1000% true and so important. Beth, is there anything that we didn't speak about today that you would like to leave our audience with?
Um, I hope that everyone continues to find doctors and healthcare providers that they are comfortable with, that are good fits for them, and that can help you to achieve your best health and your health goals.
And where can people find you?
You can find me online at Northern Virginia Family Practice. Our website is nvafamilypractice.com and on LinkedIn under my name, Elizabeth Cilenti.
I love it. Well, thank you so much for doing this today.
Thank you so much. I really appreciate it, and I hope you have a wonderful day.
I hope you enjoyed my interview with Beth. It was so eye-opening, and I love the fact that she's balanced, and I love the fact that she understands women in perimenopause and menopause. So if you enjoyed today's interview, please share it because the more you share shows you care. And please take a moment to leave a review of our podcast and rate it because when you do both of those things, it shows the algorithm that you're enjoying our content and it sends it out to more people so that we can help more women in perimenopause and menopause. Thank you for spending the last little bit with me. I know there's a lot you could be doing, but instead, you chose to spend your time with me. And for that, I am grateful. I'll see you at the next interview.